Hello, we're going to discuss bleeding infection and inflammation lunchtime. Um, so inflammation and infection, what's the difference between the two? Well, the big difference between the two is that there's a pathological organism involved in infection, whilst inflammation involves the same kind of processes in infection and inflammation, particularly in characterized irritation, tissue injury, and redness and swelling. So the only real difference between the two is the infection involves pathological. Let's look at the 5 pillars of inflammation. There would be heat, redness, swelling, pain, and if the infection lasts longer than that. So we know that inflammation is a response to invading foreign bodies or what is thought foreign body by the body, and it's called tissue damage. There's a vascular reaction and a cellular component. And these are all mediated by things called cytokines. So what seems to happen is there's a recognition of the injurious agent, recruitment of white cells, then hopefully removal of whatever is causing the inflammation, doesn't always involve immune. Then some control of that from repair. You know, for example, with COVID that we discussed yesterday, that there's a failure in the system, and these patients go on to get fibrotic changes. This is a cartoon of what was happening in the blood vessel during the time of infection. We can see that what effectively happens is that capillaries become leaky, proteins called cytokines pass through, and these then attract white cells, macrophages, and lymphocytes, and they're attracted into the system. Sorry about that. These get attracted into where the inflammation is present, and this is part of the immune response making them feel better. So again, it's all related to this vascular permeability. Normally there is an equal pressure between within the blood vessel and the osmotic pressure from outside the interstitial fluids. But the first thing that happens when there is a site of inflammation is that there is leakage of fluid, which moves out into the surrounding tissue. That's what known as edema. And this is a protein which goes through the cytokine, and this continues that process to make the fluids more leaky. So you get further leakage of both protein, fluid, and eventually cells into the sites that we get the of inflammation. And we can see that part of the process is we get this recruitment of leukocytes, and these both macrophages and lymphocytes, and by electron microscopy, you can actually see that these attach to receptors on the surface, the inside surface of the cells, particularly ICAM, and what they seem to roll along the inside surface, and then they pass through one of these holes. Primarily, these are white cells, but there is also some platelets and red cells and pass through. So what can happen? Well, you get these inflammatory acute reactions, and what you hope to do is get some resolution, particularly with infection, that might go via pus being formed. If not, you can either, with the pus forming, you get a more aggressive immune response, which can block some fibrosis, or the acute infection can become more chronic, or chronic inflammation, as we may see on things like Lymphoid. And this tends to lead on to fibrosis and function. So what are the kind of differences between acute and chronic inflammation? Well, in acute inflammation, you get fast onset of symptoms, minutes or hours. It's mainly neutrophils that are involved initially, and tissue damage tends to be mild and self-limiting. But you often get very significant local signs, such as arthritis. Chronic infection inflammation may take longer days or even weeks. It tends to involve a mixture of cells, monocyte, macrophages, and lymphocytes. Your tissue damage tends to be more progressive and severe. Again, you see the symptoms like long COVID. Less prominent symptoms, but they can be subtle. What kind of organisms can occur? It depends a little bit on the kind of patient that you've got and things like that. So the infectious agents that we deal with are prions. These are tiny bits of protein, particularly involved in infection in the brain, and viruses, which are strands of DNA and mRNA. We didn't think much of viruses until recently when they seem to stop the planet for the last 9 months. Bacteria, the most common types of infections that we think about. Bacteria can survive outside of cells and outside of the body for a short period of time. Fungi are a version of single-cellular organisms that can incorporate together. They can survive in spore form for up to 100 years. Then there's the sort of motile organisms like protozoa, little worms like home, which also cause infection. So it's a cartoon what sort of happens when we get chronic infection and inflammation. This is what we try and follow, is that we try to follow the white cells that are passing through the cell wall. If we label those white cells, we will get an idea of where there's infection. The two other things is to look at the metabolic rate, Acute, or look at the small proteins that So in terms of imaging infection inflammation, there really is very little difference, unfortunately. We don't really have any infections agents. People look at these and fail to really find anything that differentiates cell inflammation and infection. And it really just depends on the pattern recognition, the site of where we see abnormality, and what we know about the patient before they're imaged. The kind of radiopharmaceuticals that we can use for those that target the host immune system are things like HIG, they were white cells, and antibodies, some of the interleukin, FTG itself, gangliosides, etc. There are some agents that will label the infectious agents, like the TB has uptake of gangliosides. They're labeled antimicrobials, such as levothyroxine, and vitamins such as levothyroxine. None of this are in routine use. There is some more research we've done recently looking at antimicrobial peptides, particularly the ubiquitin. So in the single photon imaging infection, success depends on a number of factors. We need to understand the clinical background of the patient. Are they immunocompromised or immunodeficient? Understand when a sensitive test is need back to PUO, or where you have a specific test. For example, you know there's a condition, but you need to know where it is. You have to be pragmatic. There's no unique availability, cost, and time. Also, do the best that you can do, and that means these days I respect some infections may only be seen by some techniques, such as TB, sepsis, and remember, every patient works, and one patient might not work. Gallium-67 citrate, first of all, you can look at, no cell labeling, has a multitude of gamma energies. Some of these are quite high. We normally use a medium energy collimator to try and get reasonable counts, but high energy gammas, even though there's only a small yield, can result in quite significant gamma scatter, which results in pictures looking quite fuzzy. The dissymmetry is poor, so we're limited to at most. Indications limited to things like sarcoids, spinal infections, and immunocompromised patients. To be honest, FPG PET does this better, but you can still use SPECT-CT at 24.48 grams. Here is gamma-C7 in sarcoid, with that's meant to be the panda sign down. The lambda sign, which is the metastatic kind of nodes, diffuse low uptake, and symmetrical impediment. We can also get uptake in joints in the liver. The more specific agents include things like labeled white cells. There may be limited access to this because you need to use the cell labeling suite. India itself has quite high energy photons at 174 to suitable 5 kV requires mid-range remoter. So symmetry level 4, so it can be 20 megabecquerel. It is the gold standard for specificity and can image all the spinal infections as long as they're bacterial and fungal. It can image up to 20 hours, and the best spec is for 24 hours. Technician label white cells, again use cell labeling. We can use 200 megabecquerels, but with low radiation dose doing that to 20 megabecquerels. It's less specific than indium, but there's no real evidence that's in skilled hands that's accurate. Again, it can be used in almost all bacterial and fungal infections, but not spinal infections. We normally image up to 4 hours in the abdomen, but because you get normal ductal activity after that, we can do late imaging and you can do SPECT CT 3 to 4 hours is a good time to do it. So this is an infected knee prosthesis image with technician labeled white cell. See very intense uptake around both components. Antibodies, there are 2 types. There's anti-C6, which labels granulocytes. No cell label is needed. It comes as a straight injection. It's similar, uses similar in the patterns of what you see a very similar HMP white cells. It's very widely used in many parts of Europe. Then there's Nucascan, which doesn't really have any specific cell labeling. Mechanism of action is clear. It doesn't cause any kind of allergic reactions you can do with scanning, and is mainly used in both infections as blood flow remains high and symptoms. Again, you can do SPECT for 24 hours. Just to remind us that about sensitivity and specificity, this is a slide from my colleague at Quebec from Switzerland. And if you look at panel B, this is a patient who has a left ventricular assist device or something happening with their heart. And this is supplied by power through a lead that goes out through the skin. The patient has got a fever, so we go on that DG PET scan, which is panel A, and you can see uptake around the actual device and the however, they're all concerned about this, so they also do an anti-granulocyte antibody study, a bit like all the technical white cell study, and you can see there's absolutely no uptake around device in the heart, but there is uptake and the lead. So what they need to do is not change the device, but just change antibiotics. When we're doing these single photon techniques now, SPECT CT should be our method of choice, and has been since 2006. Initially, Roche and I looked at using gallium, and showed that you get an improved reporting of gallium. It's 11% of patients there was a major change, mainly to do with localization and improved specificity. And the specificity itself improved by 26%. Another paper looking at a small number of patients to SPECT CT using indium-11 and gallium-7 stated that SPECT CT added value in anatomical localization 65% of patients and improved diagnostic confidence in 71% and altered interpretation 47%. This is a very nice paper from Haifa, published in JNM. And this is a lovely example. It shows why SPECT CT is more accurate. So here they said 48% more accurate. This patient has had bilateral graft going, or what's called a trouser graft going from the aorta down to the back afterwards. They spike a fever, they do a white cell on panel A, the planar image, it looks like the accumulation is going over that graft. But when you do a SPECT CT, it's very clear from panel B that it is in fact a infection. And in the CT only component, you can see the arrow is pointing to the graft. And that's very good news because that can be treated with just aspiration by ultrasound and antibiotics, and the graft doesn't need Gallium-67, unlike technician products, has no renal excretion after the first 24 hours. So it can be used to look for renal infections. This is a patient with a renal transplant and a fever. This is published in the World Journal of Medicine. And you can see the accumulation of the activity within the transplanted kidney system with a pyelonephritis. And you can be certain of that because we know Also, gallium is used in discitis, as a 85-year-old man with severe backache. Has got a pacemaker, so can't have that alarm. And here you can see intense uptake. We knew that patient had an infection because they had gram-positive clots in their blood, but we can see this nice uptake here. This is not my study, this is from a publication on our mini, but you can see a patient comes with kidney disease. And again, with gallium, you don't get normal renal excretion, so when you see uptake in the kidneys are abnormal. And here, one of the cysts in the breast has intense blood pressure with gallium and is therefore infected. But I think without SPECT-CT, we would have very the same. This is some work by Paula Erber looking at infections for grafts, comparing 55 patients, SPECT technique, SPECT-CT, ultrasound, CT, and clinical criteria. And it was clear kind of the only technique with very high level sensitivity and specificity is white cells and SPECT-CT. But CT alone was sensitive very, very less. And they noted that SPECT-CT reduced false positives 37% of patients. So for this kind of condition, it is ideal. And this is an example from Cambridge. There are two patients here. The patient on the left has intense uptake seen as a big graft on the left side, and this is due to a broken infection. More difficult to see is the panel on the right. So this is the patient with what's called a trouser graft. You can see there's soft tissue mass around the trouser graft. It does have definite uptake of immune white cells. Now, you can't have immune white cell uptake unless it's either bone marrow, liver, or spleen, or an infection. So this is a low-grade infection. So sometimes the changes can be quite subtle. Sometimes they're not, but it's still useful because in this particular case, we knew the patient had an infected total hip replacement. What we wanted to do was track the extent of that infection for the orthopedic surgeon. And here, you expect CT counts mostly some certain infection. Diabetic feet. Unfortunately, diabetics often get problems with their feet. And there's a really big issue here because what you want to do is that you want to try and ensure that you can differentiate between infection in the bone, which results in amputation, for example, and soft tissue infection, which is just identified right here. So here we have a case. We've got 3 different images from a technician white cell scan, 1 hour, 4 hours, and 24 hours. And we can clearly see the base of what looks like a big toe. There's both uptake of activity, and it's here in the SPECT study. SPECT-CT, however, which is the coloured panel on the right, shows that in fact the infection is in the pulp of the big toe and not in the bone. So the treatment is not amputation, just removal of soft tissue and antibiotics. Overall, when reviewing the literature, we can see that the best contribution is seen whenever we use SPECT-CT, with sensitivity and specificity reported up in the high range. Whilst plain of white cell imaging is about 72 and 90%, with specificity as low as 67%. This is a classic clinical example of where you want to use in the white cells. So this is a 4-year-old child with multiple problems with learning disability. She was born deaf and then had cochlear implant. Peak temperature afterwards. We were very concerned that the patient may have infection of cochlear implant. She didn't want to be afraid of it without the scanning room. So we arranged to do a single scan 24 hours after injecting into white cells of SPECT-CT only of her head and neck. And here we found that there was a retropharyngeal abscess, which was caused by an incident in a retractable mesocyte operation. And there was nothing, no infection in her head. We move now to PET. Now, PET is interesting because obviously we primarily use FDG. And when using FDG, when we're doing cancer, what actually we know happens is that within cancer there is these cells tend to be a little bit hypoxic, but there's a change in the way in which the Krebs cycle works, which results in a buildup of lactic acid. And this, which is the feedback mechanism that brings in more glucose, turns more red. In infection, this doesn't seem to be the case. There seems to be a different kind of metabolic drive, which is driving glucose into the cell, which is not a lactate dependent, but maybe related to some degree of hypoxia. This has been investigated by several people, both in the Netherlands and Japan, and they have related that there has been a relationship in infection between sites of hypoxia and the presence of cytokines and uptake of FDG. And this is a very nice study done with cytokine and cell cultures, and you can look at the bars and see the percentage uptake of FDG. It actually is tritiated FDG, it's easy to measure. The control, which is the saline, is the clear bars. But you can see the effect of TNF-alpha on all types of infectious inflammatory cells, including macrophages, neutrophils, and fibroblasts. And interleukin-1 has an effect on neutrophils and fibroblasts, and interleukin-6 also has an effect on both neutrophils and fibroblasts. And these cytokines seem to stimulate the inflammatory cells to take up FDG. So we can see most inflammatory conditions with nuclear medicine. We can look at blood flow, that we can use a two-phase bone scan, or we can look at bone turnover with bone scintigraphy and FDG if it's a bone inflammation. But also we can look more directly at inflammation of white cells, or these days with FDG PET. The sarcoid is a good example. It's a chronic inflammatory granulomatous condition. There are various patterns that we see involved with saliva, lacrimal glands, lymph nodes, the CNS, joints, skin, and pulmonary. Pulmonary is the one we worry about. To get pulmonary sarcoid, your survival is very poor. Why do we do imaging? Well, to be honest, it's because biopsy is difficult. The blood testing which use serum ACE is only possible in 2% of cases. And it can look clinically like lymphoma. We have been using gallium since 1967, but it's not very used these days and has quite a high radiation burden, as we discussed. FDG, however, is very useful because lymphocytes are FDG avid, and you get a much improved resolution, reduced radiation dose, and it gives you a cleaner imaging than gallium, and also you can actually quantify uptake. So this is a paper from Japan in sarcoid comparing FDG and gallium. So you can see in panel A, there's not really much to see on the gallium scan, but panel B shows you intense uptake in the high-level lymph nodes. And then panel C is what happens after the patient receives steroids, and you can use it to monitor the response to treatment. And overall, you found that in the pulmonary disease, gallium found a 12%, and FDG 100%. Outside, gallium dropped to just 48%, while FDG stayed high at 90%. And the SCB max is about 5, so they should be. About rheumatoid arthritis, well, there's a mixture of techniques. We can use bone scans, MDP, or even sodium chloride PET-CT. We can do, but these all depend on there being bone damage and bone turnover, and these diseases tend to start with synovium, so soft tissue. People look at HIG, consumed globulin, and this has proved to be quite good, but it is difficult to quantify. Whilst FDG PET will enable you to quantify and look at therapy, disease, etc. So, first of all, looking at bone scintigraphy, you can do two-phase imaging to look at pull, but remember, don't do that next to skeleton. You can take extra pictures for the same radiation dose, which is very useful. And we always suggest extra pictures of hands and legs, and discuss yesterday bone scanning. And the pattern itself can be very useful. You can do sacral quantification, but I don't find that particularly useful. This is a patient with early rheumatoid arthritis we saw yesterday, and you can see here that there is uptake here in the metacarpal proximal phalangeal joints and a little bit of forward deviation, worse on the side than the other. And you can see the wrist uptake and knee uptake, showing you the extent of the arthritis. In psoriatic arthropathy, again, you get increased blood flow. Again, we saw this scan a couple couple of days ago, with asymmetrical uptake within the small joint of the feet. Again, this is a good way to monitor response. However, probably the best way is to use FDG, because the advantage of FDG is that we'll see inflammation in the synovium. And here in the right knee, you can see in this patient with active disease that the uptake of FDG is exclusively with the synovium. So you're able to pick up synovitis, so it's just an arthritis. When we do FDG PET, we have to think a little bit like cancer. What is the extent of disease? So the patient on the left, these are all patients that just came through our clinic. The patient on the left has got primarily lymph node disease as well as an inflammatory mass in their leg. They don't have much joint disease or rheumatoid. Whilst the patient on the right, you can see here, has got a lot of synovial uptake. You get the rings of synovial uptake of FDG, which is symmetrical, looking like rheumatoid from the shoulders, elbow, wrists, knees. Rheumatoid often saves the hips. There is also uptake in the neck, and the SPECT CT showed this was at the junction of the Lymphoid peg in C1. This is quite dangerous because that Lymphoid peg can fracture and result in destruction of the spinal cord at level, which is fatal. There are some papers on this, again, showing that a fairly good correlation between FDG uptake and joint swelling and pain. But joint swelling and pain can be due to post-inflammatory damage, so it's not really looking at the same thing. This is a picture from their paper of a normal patient and the patient with very active rheumatoid arthritis. And again, you see the distribution around the synovium of the knee. In the small joints and hands and feet, we just don't have the resolution to see that synovial uptake is different from joint uptake. The group at UCLH used FDG to look at newly diagnosed arthritis with rheumatoid and seronegative, and showed a good correlation between symptom presence at sites of FDG, and looked at the change in SCV max, showed again a good correlation with both clinical response and change in CRP when the patient was treated. This is one of their patients. It's not probably the best study. We can see that generally there's less activity in the post-treatment scan, but in the knee, one needs to put it better and a little bit worse. And it's often steroids. Retroperitoneal fibrosis, not such a big published paper. There's one good paper in Denmark, 26 patients, 20 were positive for retroperitoneal fibrosis with a good correlation with CRP. And it can be used to monitor the effect, and particularly since it gives a much better long-term effect than CT. This is a slide provided to me by Professor Signori from Rome, a patient with retroperitoneal fibrosis. He's originally scanned on steroids. You don't see anything. A year later, off steroids, there's uptake in the peri and aortic soft tissue mass. This improves in October 2010 on steroids, and they decided to keep the patient on steroids, and there remains no level of infection. Vasculitis has been FDG PET is widely used in giant cell arthritis. It used to be called temporal lobe arthritis, but now we know it's systemic disease, giant cell arthritis works better. And there's a good correlation between any changes in the cell walls in the CT and also the SR CLP. And there's again a paper published in University College London showing that we would use this technique to monitor the effects of steroids. Here we have a patient from Cambridge, and this is a coronal view, and you can see there's FDG uptake in the wall of the aorta. Also, there is uptake in the right subclavian and left carotid arterioles. Here we have an aortitis with a sort of candy stick appearance of uptake in the aortic wall. Whenever we're looking at FDG inflammation and infection, we have to be aware of the normal distribution and normal sites of uptake like neuropharynx, muscles in the neck, fat uptake, gut uptake, ureters, salivaries, any lymph nodes that may be involved, bone marrow uptake, ovarian endometrial uptake in the women, brown fat, and the first brown fat was the lactating breast tissue, and even some glandular breast tissue. Artifacts, and particularly if you're looking at infection around a solid object like a pacemaker, then you need to check that the uptake of both the attenuated and non-attenuated correct images, so you're not getting attenuation correction after that. But the good thing is that you can use serial imaging in ACB to monitor the effect of treatment. Talking about infections, if you look at PUO, this group from the Netherlands, 35 patients with PUO. 19 of them had a diagnosis confirmed, and 37 of these patients, the PET scan was used for. I have to say there's a lot more than we have. We probably find about 50%. But a negative predictive value would seem to be associated with good survival, and they called it 65% of these clinically. This is one of our patients. It wasn't so much of a surprise to get a fever because it had otherwise been good well with abdominal pain. But you can see here there is uptake in a thickened peritoneum with an overlying skin fever, and this is ongoing peritoneum. One of the big advantages of FDG PET is that you can use this in patients who are neutrophilic, and this is work that was done from the Netherlands, looking at 28 neutrophilic patients following chemotherapy. All of them, of these 26 had a positive FDG PET, and they were either in the GI tract, around injection wounds, or in the lungs. And you could find both bacterial and fungal infections. This is one of our patients, and you can see here, this patient had a bone marrow transplant, so they're very aggressive breast. Multiple focal uptakes in the chest, which can be due to box. There's also a low grade, but not bacterial, caused pancreatitis. Diabetes and infection. Well, diabetics have an increased chance of getting an infection. Hypoglycemia may be an independent factor, but it may be related to vascular insufficiency, change in the immune system, and neuropathy, and also having more skin contaminants. Not everywhere is good for breast imaging. We're not very good in the urinary tract, things like the foot, the sternum, and some other areas we could be very good. So these are two patients. One patient has a glucose above the level we would normally use when doing tumour imaging, but shows we can still see very nicely osteomyelitis and fourth metatarsal. The panel on the right is more of a mystery. This patient had a amputation, and the blood glucose was very well controlled, but there was no uptake at the site of the wound, even though the wound was affected. It's unclear why this is the case. So Rivkin looked at the effect of blood sugar and a diabetic diagnosis on false negative rates of PET scans in a fairly big group of patients, and found that in patients being imaged for infection inflammation, it made no difference whatsoever. Though there remained a significant difference in patients being imaged for cancer. So our recommendation about being normoglycemic for cancer continues, but we're more relaxed in diabetic patients with infection. So their conclusion was neither in diabetes, neither hypoglycemia, nor the diabetes itself has an impact on the false negative rate of FDG infection. This is a nice example. This is a patient where you can see the SPECT CT. There are multiple sites of bone uptake in a diabetic with a non-healing wound on the foot. So this patient is heading into having a whole foot amputation. But a PET CT was done, which showed that uptake in just the third metatarsal, and this could be removed by what's known as a ray amputation. The patient was able to preserve the rest of their feet. So FDG PET was able to give a much better answer than just the bone scan alone. We talked about vascular grafts with white cells. How does it work with PET? Well, a study published in JNM in 2007 that 39 patients showed a very high sensitivity and specificity, and this has been confirmed in other papers as well. And certainly it showed that the sensitivity and specificity was much higher than relying on CT alone. This is an example from that paper, and you can see here that this patient has got two grafts in their iliac arteries, and one of them got infected just above the left knee. That's the first panel. Then 6 months later, they got an infection in the other side around the graft. And you can see that on the left image how long and extensive the infection is, and then the slices, you can see the uptake of FDG around the graft that would need to come out, unfortunately. Just to remind us, not everything that looks like infection could be infection. This is a 41-year-old patient who had hepatitis symptom TB with night sweats. FDG suggested the patient had an abscess around the site of their adrenal glands, but in fact what they had was Hodgkin's disease confined only to their adrenal gland. If you want to know more, and if you want some guidelines on both who we should scan and on reporting, then please refer to the NMI guidelines for FDG imaging for the infection information. These came out in 2013, and as you can see, I'm one of the co-authors. And it looks, in that there is a meta-analysis table looking at the results from a whole series of trials with a reasonable number of patients and shows the estimated sensitivity and specificity for each group. And certainly, it does seem to be demonstrates to be a very technically capable study with generally across the board good sensitivity and specificity. So in summary, a single photon versus PET. Well, single photon, we have a choice of agents, and we can choose an agent depending on what we think about the patient, particularly if they're immunocompetent. SPECT-CT is now the standard, but you do need to have some enabling facilities at time to do the scans. Most of these require at least 2 scanning times. But it does offer very high specificity, so very good if you're doing a sort of search thing. And if you want to know that the breaks have an abnormal uptake or abnormality on CT and MR, is that infection, is that the site of infection, then it gives you a lot of specificity. FDG PET-CT, on the other hand, can find infection and inflammation. There's a lot more experience in the UK and probably some using it. As long as the patient is faster, they can be done much quicker, and the turnaround tends to be a lot faster. It can be used in immunocompetent and immunodeficient patients. The sensitivity is certainly better, but probably the specificity is not as good. And that is the end.